Hello friends, this is a case of minigastric bypass, and this surgery we are performing robotic assisted. Here Mantra robot will be used, but it is not a total robotic surgery. We will only perform the anastomosis part and the the suturing closure of the anastomosis perforation by the Mantra robot, and the remaining stapler firing we will do manual because Mantra does not have its own robotic stapler, and even in the Da Vinci also we use our own stapler because intuitive staplers are very expensive. So, only suturing part we will do by robotic, and the initial part of the stapler to make a gastric tube we will do by the laparoscopy. So, let us see this video, it is interesting. This patient has a BMI around 48, and we will do the minigastric bypass, which was started by Professor Rutledge, and it is one of the realistic surgery. Here is a this liver retractor, Nathanson liver retractor is retracting the left lobe of the liver, and then we have to start. It is important to keep in mind that in cases of minigastric bypass, you should not make the gastric tube less than 12 centimeter to prevent the biliary stricture. So, here we are taking approximately 15 centimeter from the GE junction. At the lesser curvature you will make a retrogastric tunnel, and you must have to see the posterior wall of stomach, so that you can fire the horizontal row of division with the endo-GI linear stapler. Minigastric bypass is a easy surgery, it is a straightforward procedure. Not very difficult because anastomosis will be anticolic. We can see here the retroperitoneal retrogastric tunnel is formed and posterior wall of the stomach is visible, and the lesser curvature window has been created, and this is the momental bursa that is below the stomach at the level 15 centimeter below the GE junction. So, this is the posterior wall and this tunnel is formed. Now, this is the stapler and blue cartridge. You can use blue or purple, both you can use, and this will do the horizontal row of division, and that you can cut 45 mm, means 3 times you will fire and you can take it back. Make it that it should be completely horizontal, it should not be oblique. So, this is fired, and now we will pull the blade back, and this horizontal division is done. Now, the vertical row of division will start, and in that you have to keep on firing till the angle of his, better to go 1 centimeter lateral to the angle of his, that is gastroesophageal junction. In that approximately 5 or 6 stapler will be required to reach up to the diaphragm, up to the fundus of the stomach. So, this is the first cartridge. If the patient has, you should also be careful that posterior wall of the stomach, all the adhesions should be removed, especially if the patient is alcoholic and a smoker. There will be posterior wall of the stomach will have a lot of adhesion, which you should clear before introducing the stapler. So, this is the first cartridge, and we have the bougie here, that is 36 French bougie gastric calibration tube. You have to put towards the lesser curvature. Now this is the second cartridge. These all are vertical row of division. We should try to remain near the gastric calibration tube. So this is second firing is started, and second cartridge has done the job. Now for further we will do some removal of the fat at the level of angle of his, and it is better because you will get the exact angle also you can see, and the thickness of the stomach in this area also decrease, and you will identify that where is stomach and where is esophagus. So assistant is pulling the greater curvature laterally, and you can remove some of the fat, that is both the side, anterior as well as posterior. Posteriorly also in this area little adhesion is most of the time visible, that adhesiolysis should be performed. So we can see just above is the diaphragm, and this area is separated. Now this is the third stapler cartridge which is getting fired. When you fire those cartridge, it is better that you should try to spread the stomach all around the cartridge of the stapler, because if you will try to hold the more amount of the stomach, there will be corrugation and there may be chances of leak. So it is better that it should be nicely spreaded anterior and posterior both the side. So this is also done, and now fourth cartridge. This is posterior adhesion is identified. If you have a adhesion, you need to separate it. If it is not, it is good. You are lucky if there is no adhesion posteriorly. Both the tip of the cartridge should be visible, then only you should fire. This is the stapler of the Lotus company, and now little bit still is left behind. For that, this is the fifth cartridge we have to fire. Do you know, even if the little bit is there at the tip, you should not try to clip or not try to use any other knot or anything. Better to spend one more cartridge and cut it. In the case of sleeve gastrectomy, generally we must go 1 centimeter lateral to the angle of his 3 centimeter from incisura angularis, and 6 centimeter from the pylorus, and that is what we go say dog ear, because that area has the minimum blood supply and the chances of leak maximum is there. However, these chances of leak is not much in cases of mini gastric bypass, because it is a low pressure zone. Sleeve gastrectomy is a high pressure zone, because you have above gastroesophageal junction and below is pylorus, but that generally does not happen in cases of MGB, but still you have to be careful that do not go and touch the this esophagus, remain little away from the esophagus. So, this is firing the last cartridge. And it is done. Now, we have the gastric tube ready and there is a bougie inside which you can see. Now, the next step is that we have to identify the initiation of the jejunum. You will lift all the transverse colon and the omentum, and then you have to go to the triangle of trees, ligament trees, and at the ligamentum trees you will find out the first part of jejunum, and from there you can calculate how much amount of the bypass you will do. That depends upon the BMI of the patient, age of the patient, and also depending upon the dietary habit of the patient, like patient is vegetarian or patient is non-vegetarian, patient is carbohydrate eater or patient is grazer. These are the factor which we will decide that how much. 1.5 to 2.5 meter, you can 150 centimeter to 250 centimeter, you anywhere you can do the bypass. So, here patient is a non-vegetarian, you can do less amount of the bypass, because they do not have vitamin B12 problem and they take a lot of protein. So, here we can see this is the ligamentum trees, and from here every time you will walk over, and every time 4 or 5 centimeter you have to use a bowel grasper, and every time 4 or 5 centimeter you will walk over. Take care that always when you walk over to calculate the 150 centimeter of the bowel loop, we should keep the bowel loop towards the your right, that is patient left, so that accidentally you should not do any torsion. So, here 50 time we will calculate, and if you are taking 5 centimeter every time, then 30 time you have to calculate. So, that 150 centimeter we are going to do the bypass here. So, this surgery is also called as one anastomosis gastric bypass, or also called as loop gastrojejunostomy, because you will just take a loop. Unlike the Roux and Y gastric bypass, you will not make a Roux limb. So, only one anastomosis will require, and it will do the loop gastrojejunostomy. So, now almost our calculation is over, just few more time. And now it is ready for the side to side anastomosis with the gastric tube. Now, here we will stop, and then we will do the docking, and then we will start robotic. However, even laparoscopic suturing can be performed, but patient wanted to have the robotic anastomosis. So, this is doctor, and here we have the Mantra robot, that is made in India robot, and now this is the gastric tube and it will be perforated. So, that you can do the anastomosis. So, we are using the Da Vinci 2 atraumatic grasper of Da Vinci to hold the gastric tube, and with the harmonic it is perforated in the middle. to make a opening in the stomach so that the jaw of endo-GI linear stapler can be introduced. So, now this is done, this is opening is made. It should be minimum 8 millimeter opening, so that comfortably you can introduce the endo-GI. And now this is anti-mesenteric border of the jejunum, which you have to perforate again. Be careful that you should not damage the other opposite wall, and it should be also taken care of that only serosa should not be open. You have to have a full thickness puncture in the anti-mesenteric wall of the jejunum. So, bile should be visible and your instrument or grasper should be able to enter into the lumen. So, it is, you can see clearly it is opened. After that, this is the side to side anastomosis. Now, how much long side to side anastomosis is good? This is also a controversial thing. Some surgeons they use only 30 mm anastomosis, some surgeons they use 45 mm. Original Professor Rutledge was doing 60 mm. However, some surgeon why they do not take 60 mm, because in their opinion that if it is a big hole in the anastomosis, there may be a chances of more dumping syndrome. But dumping syndrome is actually in one way good, that it gives your patient and it prevent your patient eating tons of sugar. So, that patient will take protein and they will stop taking a lot of carbohydrate, a lot of glucose or any sweet or any juices. So, if you will give a very small, then in our opinion it is not good. So, you should have a good size of the side to side anastomosis. So, 60 mm or 45 mm is better. So, here the stapler has been introduced up to the base and now it is fired, it will be fired. And you can see your left is the gastric tube, right side is the loop of the jejunum. When it is done, now you will remove the cartridge and then this opening of the stapler should be closed by the suturing. So, here we are using the barb suture to close the opening of the stapler, and this will be suturing will be done by Mantra robot. So, first this posterior angle will be sutured. So, one side out to in and again other side in to out. You should take a good healthy margin, and with the curved needle you can start from posterior wall and then you can go to anterior, means from down to top. You can do 2 layer or single layer. So, you may do first layer full thickness and then you can muff it by the second layer, that is seromuscular. But even single layer you will do airtight, that is also fine, and after suturing it we can do leak test by just putting the methylene blue diluted in the saline, and then you can try to distend to check the any leak of the staple line or your suturing. So, this is the starter knot. However, in many of the barb suture like V-lock, you have a loop there. So, you will pass the needle through the loop and you do not have to tie the starter knot. But this is the another company barb suture where there is no loop. So, this will be a continuous suturing single layer. So, in the jejunum side we are out to in, and in the stomach side we are in to out. Left instrument is needle holder of the Mantra robot and right instrument is a traumatic grasper. We have both the robot Da Vinci as well as Mantra. Mantra is open console robot and Da Vinci is closed console. Both is good. Mantra is better in very one sense that it is affordable, cheaper, and it is made in India. Barb suture has one problem, that it has little memory. So, playing with the suture, holding the needle is little difficult than the simple vicryl, and even simple vicryl also can be used to close this opening. It is not necessary that you always use barb suture. Now, this is the last knot and we will terminate it here. In the barb suture, termination may not be required because it is unidirectional. Even directly you will cut it, it will not go back. But in case of bobble, it is recommended better to terminate, because you should not completely reply upon the company which say that it does not come back. In cases of myomectomy and other surgery, you may take the risk, but in the bowel you should not. So, it is terminated and now needle is, suture is cut, and then assistant will put a grasper to take the needle out safely through the wound. After that, we can ask the anesthetist to push the bougie into this anastomosis, and through the bougie you will take two graspers just to hold the afferent and efferent loop of the jejunum, and then diluted methylene blue can be used to check any leak. So, anesthetist is pushing the bougie, and here this is the bougie coming, and it is going to the efferent loop. So, make it sure that you have a good opening and there is no any stricture. So, it is fine. After that, afferent and efferent loop both can be held by one atraumatic grasper, one for efferent, another for afferent, and then you can tell the anesthetist to put the methylene blue through the bougie itself, and we can see it is distending. It is distending, but there is no leak, no blue color has been seen all around, and you can check it that it is fine. So, thank you very much for watching this video. This was just a simple case of mini gastric bypass, and it was a robotic assisted, especially for the last part where suturing was performed. Thank you very much. Have a nice day.